we're now going to move on to our next topic. Mark Milano, who is our lead trainer at GMHC. He is a trainer extraordinaire. I will say he has been living with HIV for almost 4 decades. So he really has a thing or two to teach us about how to be self-advocates. And his topic today will be treatment updates. And, you know, given what's going on in the news, I know that he'll have a lot to share, and there will also be a lot of questions. So take it away, Mark.
Thanks, Meredith. Let me spotlight myself on the screen here so people can see. Yeah, I was diagnosed with AIDS in 1982, and I've also been an activist for over 30 years. My activism has taken the topic of treatment access as its main source, access for people in the US and around the world. And part of that access is empowering people with HIV to understand how treatment works and to understand how to take charge of their own health. I'm a big advocate for people with HIV learning what we need to know to take care of ourselves and to make decisions about our treatments. So I was asked today to talk about current issues in HIV treatment, what's happening. So let me share my screen here and we will get right to it. Meredith, we can see that okay?
Yes, I can.
Great. So I'm going to talk about some of the current issues that are being discussed. And by the way, Meredith, if somebody writes a question in the chat box, feel free to interrupt me. I'm happy to stop and answer the question before I move on, rather than waiting until the end of my presentation, okay?
Yes, we have Miss Victoria here, who is one of our amazing peer educators who will be assisting with that.
Great. So Victoria, feel free to interrupt me if somebody doesn't understand what I say and puts it in the chat box. It's hard for me to monitor the chat box while I'm presenting. So one of the big questions you may have heard that people are talking about is, do some of the newer HIV drugs cause weight gain in some people? We are seeing this, not in everybody, in certain people and certain groups of people. So I wanted to talk about this. I want to start this with a caveat that there are a lot of questions about this. There are more questions than there are answers. So go into it with the knowledge that we don't really have all the answers yet. So one of the shifts that may have contributed to this is the shift from TDF to TAF. So TDF is a drug that's been around for a long time. It's part of Truvada. It's also in some of the older drugs, Viriad, Atripla, Complera, and Stribild. And a couple of years ago, the company that makes it came out with a newer version that had indicated it was safer for the kidneys and bone health. And that was called TAF. So it's the same drug in a different version. And TAF is being used in many of the newer combo pills like Biktarvy, Genvoya, Odefsey. I'm sure a lot of you are taking one of these, and these drugs include the newer version of TDF, which is TAF. And we're going to talk about how these two drugs contribute or don't to weight gain. The other new class of drugs that may be contributing to weight gain are integrase inhibitors. Gilead went back and looked at 8 of their trials, including integrase inhibitors, Biktarvy, Tivicay, Genvoya, and found that in a certain number of people, it's less than a third of people, we are seeing weight gain over time on these newer medications. Now, is the medication causing it, or is getting healthier causing it, there's still a big debate about if it's the drugs causing the weight gain or it's something else causing the weight gain. So here are the questions that are being asked. Do the newer integrase inhibitors cause weight gain in some people? Does TAF, that newer version, does that cause weight gain in some people? Did TDF, the older version I talked about, suppress weight gain in some people? There's some indication that TDF might have prevented people from gaining weight. And the big question is if people gain weight on these newer drugs, integrase inhibitors and TAF, will switching to other drugs reverse it? In some cases, it hasn't reversed it, but we're not really sure. So the study I wanted you to be aware of is the DO-IT study. It's going to enroll people who have gained over 10% of their body weight while taking an integrase inhibitor, along with either TDF or TAF. You have to have been undetectable for at least a year. And what the trial will do if you join it is to randomize you to either stay on your current regimen or switch to a newer drug called Pifeltro, which is not an integrase inhibitor. So you would stop the integrase inhibitor, you would switch to Pifeltro, and you would take that along with either TAF or TDF. And after a year, they're going to look what effect did this have on weight gain. Did people stop gaining weight? Did they lose weight? Did their weight stay the same? We don't really know what's going to happen. If you're interested in enrolling in this, I think, really important study, go to clinicaltrials.gov. The easiest way to find it in the search box is to put doravirine for persons. That phrase will bring up this trial right away. For those of you who are in New York, there are 2 sites in New York. Here they are. There are sites around the country, though. So if you want to find your site, go to clinicaltrials.gov, which is an enormous database of clinical trials, and search for doravirine for persons. That will bring up the trial. And hopefully, if this trial enrolls quickly, we'll be able to find out the answers to these questions. Are these drugs causing weight gain or not? And will switching it stop? I want to emphasize, not everybody on these new drugs has weight gains, but some people do. And this trial will help us answer that question. So the big news in HIV treatment is injectable HIV treatment. A lot of new types of injectable HIV treatment are coming. The first one that was approved in January is called Cabenuva. It is 2 shots, one of cabotegravir and one of rilpivirine. It's a shot in each butt. Right now, you get them once a month, but within the next 6 months, that will likely be changed to 1 every other month. Everyone takes them first in pill form for a month to make sure that you are not allergic to them. The first injection you get is 3 milliliter, and after that, the amount you get is smaller, which makes the injection a little easier to take. Now, because rilpivirine must be refrigerated, you will not pick these up at the pharmacy yourself. The pharmacy must deliver it to your doctor, or if your doctor has a pharmacy on site, that pharmacy will store the drug for you. You will not pick it up like you do your other HIV meds. In the clinical trials, only 1% of people stopped it due to injection site reactions. That's pain or swelling at the injection site. So that was very rare. And over 97% of people preferred the injectable to daily pills. So they were very popular, and it was approved last January. So this is available now. If you have questions about it, talk to your doctor and see if it's right for you. It's particularly good for people who are having difficulty remembering to take their pill every day. If that's a problem for you and you want to switch to an injection once a month or every other month, ask your doctor if this is right for you. There is a long-acting pipeline for this drug. They are looking at a patch you would wear for a month. That would be a patch for PrEP. They're coming up with a formulation that is stronger, so the injections would be smaller. And they're also working at an implant that would be like the size of a matchstick that would go into your arm and be switched out once every year. So with the implant, there would be no dosing at all. You just put the implant in and you don't think about it for a whole year. So that's coming in the pipeline. Another new drug in the pipeline is Lativir. Lativir is the first drug of its type. It is the first ever translocation inhibitor. So there's never been a drug like this before. It works in the same step that many other drugs work. They're called nucleoside analogs or nukes, but it works in two different ways, which is new. It's at least 10-fold more potent than other drugs, so you can take a much smaller amount of the drug. It's being studied right now as a daily or a weekly pill. It's being studied with that drug we just talked about called Pifeltro. So it would be in combination, this new drug with Pifeltro. It's also being studied with a new Merck drug called MK8507. And if those trials work out, that would be a once weekly pill. So rather than every day, you would take it just once a week, if that works out. It's also being looked at as a once a month pill for PrEP and PEP. And also, once again, as an annual PrEP implant. So that's just something you would put into the arm every year for people taking PrEP. No more need for daily PrEP pills. So this is in the pipeline, maybe 1 or 2 years away, but it'll be a big change when it comes out. Another new drug is Lenacapavir. It is, once again, the first of its type. It is a capsid inhibitor. I will explain what that is in a second. It may work in more than one point in the HIV life cycle, which is a good thing. It makes it more effective. And it is a subcutaneous injection. So rather like the intramuscular injection in the butt, like Cabenuva is, this is like an injection of insulin. It's a very small needle that you put into a fold of skin. And the good news is it's being studied just twice a year, a small injection once every 6 months. So that would be great news for all of us. There were good results reported this year for both people who were taking HIV treatment for the first time. It was 94% effective in those people, and for those who are multi-drug resistant, who have already become resistant to many HIV drugs. And in those people, it was 81% effective, which is still a very good efficacy rate. So it's being looked at both for people starting HIV treatment and for those who have already become resistant to HIV treatment. And the good news is that it was submitted for FDA approval last June. So if the FDA likes the results, this could be approved early next year. that would be a game changer because it's also being looked at with other long-acting drugs, which would mean sometime next year, you may just be taking this small injection twice a year for your HIV meds. That will be it. Not even once a month or every other month. It might be just once every 6 months. So if that comes out sometime next year, I think that'll be a game changer. How does it work? So HIV is a very simple virus. It just has a protein coat with some spikes, and then there's a capsid in here that holds the RNA that HIV puts in the cell. That capsid must disassemble inside the cell. Lenacapavir stops that. Once more virus is made, the capsid has to be reassembled. And lenacapavir also prevents that from happening. So it prevents the capsid from coming apart, and it prevents the capsid from being reassembled, which makes it a very potent medication. As you can see, ATV, which is Reataz, an old protease inhibitor, requires this much drug to work. But lenacapavir down here only requires this much drug, a very tiny amount compared to other drugs, which is why so little of it can be given so infrequently. So we like putting less chemicals in our body, right? Another new class you're going to be hearing about, it's further off, but I want you to know what it is broadly neutralizing antibodies. Antibodies are things your immune system makes to fight viruses. They attach to a receptor on the surface of HIV. They can be used for prevention, for treatment, or to put people in remission. They have to be used in combination. You have to be tested first to make sure you're sensitive to them. Once again, they are dosed every 2 to 6 months, and several studies are starting. So this may be 3 or 4 years away. I just want you to be aware that BNABs are something you're probably going to be hearing about, and they may be an entirely new approach to HIV. Another final new drug that has not been seen before is a maturation inhibitor that prevents HIV from budding from an infected cell. ViiV is studying 2 of these drugs. They're very preliminary, but they're showing good results so far. So you might hear more about these in a couple of years. Once again, a long-acting injectable is being looked at. I want to close by talking about the cure. I'm sure you're all curious about the cure. So the cure is trying to get rid of the HIV that is hiding in our HIV reservoir. What is the HIV reservoir? Where it's made up of CD4 cells, which normally live for a week, but memory CD4 cells remain for decades after an infection. So when you get the flu, your body creates memory CD4 cells, which do not die off after a week. They live for years, and they do that by going into hibernation. Now, the problem with that is that HIV drugs cannot get into resting memory CD4 cells. That's why HIV persists in us, even though our viral load is undetectable. The HIV drugs can only enter activated CD4 cells. And HIV also hides in other types of CD4 cells. Now, the longer you wait to start HIV treatment, the larger your reservoir is. If you begin HIV treatment immediately after infection, your reservoir is very low. If you wait for years, like I did, your HIV reservoir is very big. So the reason we want people to start treatment earlier is it keeps your HIV reservoir small, and it means there's a better chance the eventual cure will work for you. They did just last month put in a new investment at the NIH of over $265 million in cure research. So cure research is ongoing, and now we have new funding for it, which is great news. What will the cure look like? Well, it'll be one of three different types. The sterilizing cure would completely eliminate the virus from our body. Every particle of HIV would be gone from our body. That's going to be really tough to do because HIV hides everywhere in the body, the gut, the brain, the lymph nodes, our organs. It's throughout the body, which makes it very hard to eliminate completely. The functional cure would keep us undetectable without having to take meds. All of you who got chickenpox, like many of us did, we are cured, but the chickenpox virus remains in our body for our entire life. It is controlled by our immune system, but not eliminated. We are still cured, but the virus persists. And if our immune system gets weak, that virus can come back as shingles. So that's the cure that is more likely with HIV. Doing a treatment that retrains our immune system to control HIV like chickenpox. So we are virally suppressed without taking any more medication. We cannot transmit the virus, and we are functionally cured, even though there is still a little HIV in our body. Remission is the attempt to keep our viral load undetectable without being on regular meds. And that remission may last for a number of years, and then we may have to do the treatment again. So you may get the treatment, it may last for 5 years, you may do it again to keep you in remission. Laureen Willenberg is someone who was infected with HIV in 1992, and she has been able to completely control her virus, undetectable viral load, without medication for 30 years. They are studying people like her to see how they do it, to see if they can retrain our immune system to do the same thing, to control the virus without any medication necessary. Possible cases of remission have been reported, but we have to follow them for many years to see how long that remission lasts. So there's my email. If you have any questions or want a copy of this, I do want to put a plug in for the I'm Still Here webinars that cover all these issues. I'll be giving the one on September 23rd on how to age physically well with HIV. I'm going to put a link to that webinar in the chat box right now. So anybody who has questions, I see, will there be an injectable HIV drug, Judith? I think I answered that in your question. And I don't know how to find a list of how each drug affects insulin. I'm not an expert on diabetes. So the best way to answer that question is to go to your doctor and ask your doctor, are any of my drugs interacting with my insulin? Your pharmacist could also answer that. Let me put this link though into the chat box for everyone to that HIV and aging webinar, which I think will be very useful for anybody. Any other questions The weight gain. Yeah, it was specific. It was the visceral abdominal tissue. It was the weight that is deep within the body that you cannot take out via liposuction. And it's very hard to get rid of that.
Okay. I think we have time for like one more question. I see one person about, do injectables, are they less toxic, and one about including women in these trials, how that has been.
Yes, women have been included in the trials, and Cabenuva is available for both men and women, and the drug was equally effective in both men and women. If you want my slides, there's my email, markm@gmhc, so feel free to email there. And in terms of not being toxic, there have been no significant toxicities in the clinical trials. However, Cabenuva is a much newer drug, so we don't know what the long-term effects will be, but at least in the trials, there have been people in the trials for up to 5 years of Cabenuva, and they have not seen any significant long-term side effects nor toxicities in that 5 years. So hopefully that will hold up as time goes on.
Yeah. So again, I'm so sorry. I know people have a lot of questions, maybe during the break. If folks want to message you, they can do that. We have
one last question about remission. I just want to say,
okay. All right.
If you go into remission and the virus comes back, most likely you will just redo the same treatment. But this is all kind of conjectural now. We don't really know. So we'll have to see what we learn from remission trials to see what you do with people whose viral load does come back after a number of months or years off treatment. Good question to be answered as trials are ongoing.
Yeah, there's always a lot of unknowns. I always really appreciate, Mark, how you kind of navigate the unknowns. It can be hard. So now we're very